Jatin Yegurla, consultant gastroenterology at Apollo Hospital. So the second case also revolves around portal vein. So we have an international patient that came to us. It's a 18-year-old female patient with main complaint of dyspnea on exertion for the last 4 years associated with easy fatigability, but she did not have any platypnea. On probing, she also gave history of altered sensorium episodes, 1 to 2 episodes per year. Each episode used to last for 15 minutes to 1 hour, and it was conservatively managed, and they did not really seek healthcare. And she also reported altered sleep rhythm and daytime sleepiness, leading to poor scholastic performance. And on examination in the clinic, she had markedly elevated JVP, and she had a parasternal heave with parasternal murmur. The CNS examination and per-abdominal examination were unremarkable. Even she did not have asterixis. So with the investigations that she already had with severe fatigability and dyspnea, we expected that she will be having some anemia, but surprisingly her hemoglobin was very good. LFT showed only mildly elevated transaminases, and with a albumin of 3.1 and platelet count of 2,20,000. For the altered sensorium episodes, for metabolic point of view, she was evaluated with by the neurologist with MRI, brain, EEG, and all the metabolic parameters including renal functions, electrolytes, TSH, and the HbA1c were normal. And chest X-ray showed cardiomegaly, and ultrasound abdomen, it was reported as altered ecotexture. And basically, the patient went to the cardiologist for dyspnea, and cardiologist referred the patient to us for deranged liver enzymes and altered liver ecotexture. So initially we ordered autoimmune markers, it was negative, AFP was normal, and on probing she gave history of recurrent HE episodes, so we did an ammonia that came out to be elevated. So we were suspecting that patient would have CLD and she must be having HE, but the FibroScan values, the LSM was normal. Meanwhile, the cardiac evaluation, patient had dilated RA, RV with severe tricuspid regurgitation and severe pulmonary artery hypertension. LV ejection fraction was normal. So in the background of liver disease and pulmonary and dyspnea, contrast echo was also done, which showed no evidence of hepatopulmonary syndrome or intrapulmonary vascular malformations. This is the CT pulmonary angiography done by the cardiologist to look for the cause of such severe pulmonary artery hypertension. This again showed similar findings of dilated right chambers with hugely dilated pulmonary artery. Here it is. So, and there was no evidence of pulmonary thromboembolism even in the subsegmental branches. And incidentally, they found an abnormal venous communication between the portal vein and the IVC. And this was ignored by the cardiologist, and when we took the history and when we were planning for liver disease workup, then we found that this was already reported in the CT, and we performed a triphasic CT to correctly understand the anatomy. And here you can see that the liver outline is normal, there were no liver nodules, and here this is the portal vein communicating directly to the IVC, and there are no intrahepatic portal venous branches seen. So if we summarize, here we have a very young girl, 18-year-old, who's coming with recurrent HE and severe pulmonary arterial hypertension and extrahepatic portosystemic communication without liver cirrhosis. We diagnosed the patient as having Abernathy malformation, and that was responsible for her HE because the mesenteric blood flow is being shunted to the IVC, bypassing the first pass metabolism. So there are a lot of amines and vasoactive peptides that are going into systemic circulation that can cause pulmonary vasoconstriction and pulmonary arterial hypertension. Also, the sheer hemodynamic volume that is being diverted into the IVC can cause pressure on the right atrium, right side of the heart. So now, how do we manage this patient? She was already on rifaximin and lactulose. She is already on sildenafil and ambrisentan by the cardiologist. So should we just continue the conservative management, or should we attempt to close the shunt? And if we have to close the shunt, should we close the shunt, or should we subject the patient to liver transplantation? Because there were no intrahepatic portal vein radicals, and eventually it is going to progress. So, and if we are choosing shunt closure, should we do intervention guided closure, or should we subject her to surgical management? So these are the questions that were there at this point of time. So before we tell you what we did with this patient, let's discuss Abernathy and then we go back to the case. So Abernathy malformation, it was first described in 1793 and it is basically shunting of the portal blood into the systemic circulation partially or completely. If you look at the types, this is very important. This underlies the management strategy, whether the patient has a type 1 malformation or a type 2. So the only difference is whether the intrahepatic portal vein branches are there or not. So in type 1, the intrahepatic portal branches are not there and the splenic vein and superior mesenteric vein join directly into the IVC without forming a common channel. This is 1A, and if they form the common channel and directly join, this is a end-to side anastomosis, and this is type 1B. So these two are type 1 and these patients have to be subjected to liver transplantation. And the person who has a side to side shunt is type 2 malformation, and these are the ones who we can try shunt closure. So most of the studies, most of the literature is restricted to case reports, but the largest series is including 66 patients, and it was an international retrospective study spanning around 30 years almost, and this also included data from 3 of our Indian centers. So if you look at the data of this study, so we can see that the median age of presentation is around 20 years, and there was no gender preponderance overall, and this is the data of 66 patients that was published in Hepatology. So type 1 malformation was seen in 60% of the patients and type 2 was in 40% of the patients, and most of the times these patients do well, especially the type 2. Only they have episodes of altered behavior, and they come from various other reasons and they get detected with extrahepatic portosystemic shunt. So 20% of the patients who were diagnosed with Abernathy came with symptoms of CEPS. CEPS is congenital extrahepatic portosystemic shunt. So among them, 10% of the patients came with recurrent or persistent HE, and 10% of the patients came with dyspnea. Now the dyspnea in these patients could be because of two reasons. One is hepatopulmonary syndrome because of pulmonary vasodilatation, or second is because of pulmonary hypertension. Among these patients, deranged elevated transaminases was observed in 25%, as was observed in our patient. Now if we look at both the types separately, so type 1 is the one which is more severe because hardly any blood was going to the liver. They are going to present very early in the age. There is a female preponderance, and there is also associated congenital anomalies, mainly cardiac anomalies, and these are the ones who are more likely to present in the first decade or around 10 to 15 years. In contrast, our patient was type 2, and she presented at the age of 18, and there were intrahepatic portal vein radicals that were detected after balloon angiography that I will be discussing later. Coming to complications, as I said, hepatic encephalopathy, portal pulmonary hypertension, hepatopulmonary syndrome, and HCC in these patients is also described. However, with very atypical findings, and the classical enhancement patterns may not be seen because of vascular perfusion abnormalities. So the threshold for biopsy in these patients when you have a liver nodule should be very low. So these patients, these 16 patients, they are followed up for almost median follow-up of 4 to 5 years, and what they noticed is that 25% of the patients eventually developed HE, although only 10% presented with HE. So subsequently there is a risk that they might develop HE even if they are asymptomatic now. So 40% of the patients had liver nodules. Most of them were FNH or regenerative nodular hyperplasia, and 20% of them were HCC. Most of the HCCs were in type 1. Pulmonary complications, as I discussed, because of the vasoactive mediators bypassing the liver and the hemodynamic load. So how do we manage these patients? Any patient who is having Abernathy malformation, who are symptomatic with encephalopathy or liver dysfunction, or even asymptomatic patients who have a shunt ratio more than 60, these are the ones who we are supposed to offer them definitive management. This was suggested by some of the people who have published the cases, and these are not societal recommendations. And all the type 1 patients, type 1 shunt should be subjected to liver transplantation, and type 2 should be subjected to shunt closure. If we go into the details, how do we plan the treatment? So the symptomatic patients, So we have to perform a balloon occlusion test to see whether the intrahepatic portal vein radicals are actually hypoplastic or they were just concealed because of low flow. So once we do the balloon occlusion of the shunt and then do the contrast study, then we will be able to see the intrahepatic portal vein radicals, and we also measure the portal vein pressure. If it is very high, then suddenly blocking the shunt may not be a good option, and people have suggested that we have to do a partial closure initially, and then subsequently when the portal pressure is slowly come down, we can do a repeat procedure later on. So for those with pressure more than 32, they have suggested a 2-step closure. For those with less than 32, 1-step closure. Asymptomatic patients should we really treat? So this was a big question, but people have suggested that somebody who is having a shunt ratio more than 60%. Shunt ratio is the amount of blood that is diverting into the IVC compared to the one that is going into the liver. So if it is more than 60%, people have suggested that they are supposed to be treated. So coming back to our case, this is the DSA image, DSA video. Here you are able to see that this catheter was passed from the IVC into the portal vein through the shunt. And once the contrast, you are able to see this is the portal vein inferior mesenteric, superior mesenteric forms the portal vein, and the contrast is going into the IVC. Here, this is the shunt. So next what we did was we did with the help of the interventional radiology colleagues, we have performed a balloon occlusion test before planning the intervention. And here in the shunt, the balloon occlusion was done, and this another catheter passed from the femoral side has measured the pressure. As we discussed, whether we should go for a single stage closure or a double stage closure. So pressure was 20 millimeters, and we decided that this is the patient who is going to benefit from a single stage shunt closure. However, the challenge was that the shunt size was very big. It was around 24 millimeters. Most of the published literature showed size of around 10 to 20 millimeters, and they used vascular plugs. But no vascular plug could fit into this size. So it was a challenging thing. So we discussed with some of our seniors in NIMS and interventional radiology seniors and faculty, and then they have suggested that we should go for an ASD device closure, and that is what we have done here. You can see that the ASD closure device is being deployed in the portal vein, the shunt between the portal vein and IVC. So here, this is the ASD closure device successfully deployed in the shunt, and after that the color Doppler showed no flow across the shunt. So this plain CT that we have repeated after the procedure, you are able to see that the shunt, the device is completely blocking the shunt. So, since the literature has suggested that after placing the shunt there is high risk of thrombosis of the superior mesenteric vein or portal vein because of the device, we decided to give them short course of anticoagulation for 3 months, and we have stopped the anticoagulation after 3 months. Her dyspnea has improved, her fatigue has improved, and patient did not have any episodes of HE since then. 3 months after follow-up, we got the echo done and arterial ammonia. Ammonia was normalized, and echo showed no pulmonary arterial hypertension, and she only had few changes of previous pulmonary hypertension like dilated pulmonary artery and pulmonary valve prolapse. So she is due to come back. She is a resident of Kenya. She is due to come back next month, and we are going to plan another echo and CT abdomen to document the 6 months follow-up. So highlights of the case is that patient is presented with severe pulmonary arterial hypertension and dyspnea. The shunt size was very large. However, we had ASD closure device to our rescue. So take-home messages: any patient who is young and coming with recurrent episodes of HE and there is no cirrhosis, suspect extrahepatic portosystemic shunt. In case of type 1 shunts, search for other structural abnormalities. And in order to differentiate between type 1 and type 2, imaging is not sufficient, and you have to do a balloon occlusion angiography to confirm differentiate between type 1 and also to measure the pressure to plan the therapy. To summarize the treatment, asymptomatic patients who has a shunt fraction of less than 40%, we can safely follow them up, and patients with type 1 liver transplant, type 2 shunt closure. Thank you.
Develop more collaterals because of this.
Sir, the collaterals, basically the shunt is going to divert the blood flow to it. There are intrahepatic portal vein radicals, and they are going to open up.
Fair enough. Now, what is the life of this particular shunt?
It's going to be lifelong implant.
Fine.
If you look at ASD and PSD, when there is a severe pulmonary hypertension, they don't put these stents, stating that lung function is not going to improve. But here, it appears to be reverse. See, patient already had severe pulmonary artery hypertension. Despite that, you have placed that device closure here.
So
Pathophysiology is same, whether it is ASD or VSD.
but here we are reducing the load to the cardiac inflow. So we are basically blocking the flow and reducing the and the right side of the heart and the pulmonary.
But in ASD also same mechanism is there. There is severe pulmonary artery hypertension. They don't place these closure devices stating that lung is not going to improve by placing these devices.
And also, once the Eisenmengers, so once the Eisenmengers are set in, the shunt,
No, there
the
is-
flow is from the right to
Dr.
left.
Srinivas, there is a parenchymal interface, no? So it's a gated reduction in the gradient, so it would help. Yeah. Whereas in VSD, ASD, there is a direct pressure impact. Here it's an indirect one, no? So it would help.
Is she off her pulmonary hypertension medication?
Yes, she's off her medication. She's off all medications.
What would be the reason for pulmonary hypertension? Is it the vasoconstrictors? Is it the vasoconstrictor mechanism, or what's
It is
happening
increased
exactly?
preload.
What
I think
might
it
have
is both
caused?
the hemodynamic overload, chronic hemodynamic overload, the sheer amount of volume that is on the right ventricular pressure, and also the theory that is that vasoconstrictors can cause vasoconstriction, and probably that these two mechanisms.
I think it's a very good case. I mean, very interesting, and we don't see much of this at all. But sometimes we do see patients who have high ammonia, who develop some encephalopathy. Nothing is really diagnosed in them. Going around as urea cycle enzyme defects. We don't do these testings. So I think in that situation, I think we should try and do this angiography and try to find out a bigger shunt and evaluate this disease.
And sometimes we do get referrals from neurologists saying that the ammonia is high and they're not able to find the cause. Sometimes they are on valproate and we attribute it to it. But if they are off medication, then we should really consider whether this patient is having this, especially in the younger group.
These referrals from neurology department is always there
Yes.
with high ammonia.
When we look at the natural history in the long run, is there liver cell failure?
So patients did have, especially in the type 1 patients, by the time they reach second decade, because hardly any blood is going into the liver, so they develop complications of liver cirrhosis and they develop HCCs, and most of them don't survive without liver transplantation, especially type 1. Type 2, there is some amount of blood flow, but in our case, the shunt fraction was more than 90%. Eventually, the fraction is going to be increased, and she is going to develop if we don't treat. Even the published literature also said that if we don't treat, they are going to develop complications of cirrhosis.
Are they more likely to develop cardiac cirrhosis than
So,
reduced portal inflow?
our patient was having pulmonary hypertension, but the previous patients that I managed back in AIMS, all of them had only recurrent HE and they didn't have any pulmonary hypertension. So this was unique because this presentation with pulmonary hypertension and this thing HE, it was unique. So probably because of the reduced blood flow to the liver is going to get cirrhosed. That is the main mechanism. Thank you.